So thank you everyone for finishing your day with us. It's actually my privilege. I plan on not doing much talking. I apologize if you've been in any sessions I've been in. We couldn't decide whether we should put up a picture of a fire or whether we should put a picture up of a swimming pool, given the weather here on February 13th. But I'm really delighted that I can be a moderator for a conversation with Tom. He's been a very loyal supporter of health management education in the executive program. We figured it was about 15 years that he's been teaching the leadership capstone class in the second year of the program. So we've gotten to know each other very well, but I'm going to play the role of interviewer, or at least kick a few questions his way, things that we thought you might find interesting, and after the conversations today, definitely fit well with the conversations that we've been having with some of the other panels and keynote speakers. So for those of you who, we have such a nice mix of students, industry, administration, policy folks, the first question actually that I'd like to ask Tom is to explain the unique characteristics of Cedars-Sinai health system, including the medical center. What gives it its business model or competitive advantage, and why do you think it's been successful with its patient population?
Okay. And this is your test for the Sunday morning talk shows, right?
Yes.
Right.
Yes. Meet the press.
Right. Meet the press. Right. Thanks, Leah. So a couple words about Cedars-Sinai and our business model. Borrowing their language from the public health school, I'd start the discussion of our business model around the mission of the organization. The Cedars-Sinai Health System mission has 4 components to it. Patient care, which is delivered both through a large physician enterprise as well as through the medical center itself. Medical education, in which we're one of the largest and most sought after graduate medical education programs in the country. And also have the pleasure of teaching the medical students here at UCLA as well. And a very broad other professional education agenda at Cedars-Sinai, from imaging technology, laboratory technology, nurses, et cetera, et cetera. And then research. We do about $130 million worth of funded research each year, about half of that from the NIH. Time doesn't allow, but a lot of contributions. Most of our research is oriented around translational as opposed to basic research, although I have to admit in today's molecular medicine world, the line between those two things is blurring pretty quickly. In terms of the structure of the organization, it's not-for-profit, community-based organization, so it might be referred to as a community-based academic medical center. Like most academic medical centers, we're really a combination of a community hospital. So the community hospital and physician organization is basically the primary and secondary care provider to 2 to 3 million people who live in the immediate area around Cedars-Sinai. But at the same time, for our tertiary and quaternary services, we are essentially a referral center for all of California, the United States, and for certain things to the world. And that is one of the unique aspects of an academic medical center business model. In terms of the population we serve, I always enjoy talking about that because most of the press coverage of Cedars-Sinai is usually either around a scientific discovery or the hospital to the stars. And my take on that, frankly, is on the one hand, I don't apologize for that because it's a statement that people who can choose to go anywhere in the world choose to come to Cedars-Sinai, and I think that's a statement of the quality of care that we render. What's unfortunate about it doesn't really tell the whole story because Cedars-Sinai actually serves all of Los Angeles in all of its dimensions. So about 40% of our business is Medicare. Parenthetically, we're the largest individual hospital providing Medicare services in the state of California by a large degree. We provide 50% more treatment to Medicare patients than the next closest hospital. And about a third of them are dual eligibles, for those of you familiar with that. So we're not talking about a Beverly Hills Medicare clientele. And we're also one of the largest providers of Medi-Cal services in the state of California, although we're not a disproportionate share provider. Because we don't meet the criteria because the denominator is so big. So in absolute numbers, we're probably the 11th largest Medi-Cal provider in LA County, but because of the way the rules work, we don't receive that additional funding. As a private institution, therefore, we really, in terms of the business model, the revenues to the institution come through patient care revenues that we render to either Medicare, Medi-Cal, or commercially insured patients. the medical education payments for graduate medical education we receive, and then the research funding. And then last but certainly not least is philanthropy, which is for all hospitals, but especially for academic medical centers, is an important part of the revenue stream to support our ongoing operations.
Good. So fantastic. As you know, the theme for today for this conference has been modernizing healthcare for the new age. And Cedars-Sinai has a long reputation in the community, which is wonderful for its brand. What would you say makes the system modern today, but even more importantly, where are you taking it, or your team is taking it in the next 10 years, 20 years to keep it modern?
Okay. So I think a couple of things. Certainly, I think in the past, our reputation for quality reflects an effort that's been present in the institution for as long as I've been there. I can't take credit for having brought the orientation to high quality to Cedars-Sinai, but that orientation has been part of the history of the organization for a long time. And as what it is we know quality to be has evolved, I think Cedars-Sinai has worked hard to continue in that, and frankly, in some respects, help define that. And that's been an important part of what we've been undertaking. More recently, as the question of value in healthcare and the cost of healthcare has become the area of appropriate concern that it is, the institution's focused on making sure that two things, that the things we do are things that make a difference and count and play a vital role in the community. And two, with regard to medical care, engaged in a number of undertakings to address the issue of clinical efficiency, to make sure that the care that people are getting is everything they need and they deserve, but not what doesn't make a difference. And so it's the whole clinical effectiveness side, I think, is an area of focus, especially over the last 5 to 7 years, and one I think will be with us on into the future. That's reflected not just in the work we're doing with individual physicians, but also work we're doing as an organization in terms of systems of care, and also our approach to the marketplace as the payment models have evolved over the years with respect to an increasing focus on so-called value-based payments in whatever form whatever form they may come. And those value-based payments in one way or another all have risk associated with them. Risk-based payments at one extreme being capitation, but all the way down through various kinds of withholds in order for organizations to earn back the full payment after having demonstrated either that they've demonstrated the ability to provide appropriate high-quality care and they've done it in a clinically efficient way, or both.
That's actually a very good transition to this next themed question. This is a really smart group, and many of you study the whole idea of transparency, costs, what does it mean for value-based care. But I would say that the lay public probably is so difficult for us to understand value-based care and outcomes and how do you pay for outcomes. What's gotten the public's attention lately is the Stephen Brill articles. I don't know if you're all familiar with The Bitter Pill. First it was an article in Time magazine, a book, but then he re-entered headlines because he became a patient himself, which is always this big moment of truth for people. Right. They know what it's like to receive care. So I believe he was in the hospital for 8 days, got a bill almost nearly $200,000, and kind of got the ire up of people again saying, did you see the price for that Tylenol? And did you see the price on the charge master for these things? Yeah. You're in a position at an academic medical center where care doesn't really necessarily come cheap. Mm-hmm. Could you comment, if either I were Stephen Brill or you were commenting to the general, yeah, maybe not that, but if you were commenting to the general population about what does that charge master mean? When Stephen Brill's talking about the price of healthcare, what is he talking about? And how are you going to survive fulfilling your mission when the lay public is upset about the price of healthcare?
Right. So I guess my own thoughts about Mr. Brill's work is, I mean, he is clearly speaking to a real issue, and that is the cost of healthcare. And healthcare in America is expensive. It's expensive for a whole variety of reasons. Maybe we can get into either in the Q&A or a little later here. But what was from my standpoint, what was unfortunate was organizing that around the question of charges.
Yeah.
Because it gives the impression that the issue is the charges and the amount of charges. The issue is the cost of healthcare. Healthcare is very expensive. Charges for the vast majority of what a hospital receives in payment aren't really relevant, and to the extent they are, because there are other negotiated prices. His book suggests that somehow the charges are increased in order to offset the effect of the negotiations. Unfortunately, charges really are just a means to an end, and they don't really have the purpose that I think he was trying to suggest. And so, because in the end, what hospitals are seeking to do is get a certain level of payment in order to keep themselves viable. And this is particularly relevant, and only relevant really in the commercial insurance world, right? On the Medicare side, Medicare has fixed fee payments of one type or another, physician and hospital services, Medi-Cal the same. And so the charge master in most institutions, again, it's a means to an end where a hospital's ultimately looking to seek a particular price. Another point about the whole issue of charges that is little understood is Mr. Burrell's article and his book somehow present it as a creation of hospitals alone and something that hospitals alone control, and that's not true. The charge system in the United States is an outgrowth of a system we've had in place now for about 50 years. And it's one, frankly, that all of us who work in hospitals would love to get rid of. The confusion that it creates, the bad will that it creates, is not something that any of us enjoy. But in order for that to change, it's going to require a cooperative effort between the federal and state governments, as well as the commercial health insurance plans. And so with regard to commercial insurance, if we could come up with another mechanism to be able to arrive at the price, then I think we and other hospitals would gladly move in that direction. Getting all those people together, because it can't happen without everyone agreeing about what the change is going to be, is an enormous undertaking. And
so would you agree to a price list?
So there are a variety of ways you can get from here to there, and that might be one. But if you're going to do that, part of the challenge and there's also what's been unfortunate is not understanding what it is that causes the charges to be what they are at an individual organization. Whether it's charges or the real price, the cost of any particular service is really a function of a couple of things. One is, what does that organization do? So to state it simply, a chest x-ray at Cedars-Sinai or a chest x-ray at UCLA is not the same as a chest x-ray at Good Samaritan, because that chest x-ray is being done in a very different contextual setting in terms of what the mission of the institution is and what the patient mix that is there to be served. Another factor, especially with regard to commercial insurance rates, is the population that the facility serves. California hospitals lose $8 billion a year, and this is not the difference between what they're paid and what their charges are. This is the difference between what it costs to provide the care, real cost, and what is actually paid. California hospitals, largely excluding the Kaiser hospitals, lose $8 billion a year. And organizations, in their effort to remain financially viable, recover some of that in their commercial insurance rates. And so there are estimates that if the losses that are sustained serving Medicare and Medi-Cal patients were not there, commercial insurance rates in California could be as much as 25% less. And so all of these things come together. And so the price of healthcare in America is undoubtedly expensive. When one then asks the question, what about the price at this facility versus another, one needs to take into account the nature of the services that are provided, as well as the payer mix that particular organization might have.
Well, that leads to the next theme that I wanted to bring up with you, and that is that this different price setting, different charges for different organizations has sometimes put you in competition with insurance companies during the negotiating time for contracts, them wanting to steer people away from the more expensive providers to the less expensive. So one of the things that has made or come from this has been interesting new relationships. And one of the most interesting that caught a lot of headlines is Vivity. So if you are familiar with Vivity, it is with Anthem, Blue Cross, previous Anthem, which has in the past been a bit contentious with the higher fixed cost institutions. And it sort of took everyone by surprise. So maybe you could explain to everyone, because I know that even in my readings, I wasn't quite clear until I heard some people speak about what Vivity is. Maybe you could explain in general, what is Vivity, what's its promise, and what do you think the critical success factors are going to be for it?
Sure. So in brief, I think Vivity represents a creative and novel and new approach to try to deal with this issue of value in healthcare. How can you assure the provision of high quality care at an affordable price? At its heart, that's what it is, and it's a different way of trying to approach that. So you're correct. Over the years, there is either an annual right or a multi-year right of spring, so to speak, in which there are negotiations around pricing. Those are sometimes contentious, sometimes not. And health plans in more recent years, and part of their effort, trying to do their fiduciary duty, have engaged in things like narrow networks and other kinds of things. And I think what's occurring, not just here, but around the country, is a realization that that approach hasn't necessarily solved the problem. Right. I think we can agree that the issue of healthcare continues to be affordable. It continues to be uneven in quality, depending on where you go and things of that nature. So Vivity. Vivity represents what I was just trying to describe conceptually. It's a joint venture, LLC, for those of you familiar with that particular structure. There are 8 owners of Vivity, Anthem, Blue Cross here in California, and 7 health systems in Los Angeles and Orange County, to include ourselves, UCLA, Memorial Healthcare, Good Samaritan, Presbyterian Intercommunity, Torrance, and Huntington. I think I've named all 7. And it's a group of organizations that have a substantial amount of experience in managed care, in capitated managed care, as a particular way of paying for healthcare services. All of us have been here in California for the last several decades, as California has kind of defined that particular payment model. And as organizations, we're believers that it can be a very effective way at trying to deal with this particular issue. And so rather than have the traditional negotiating session, we've created a jointly owned business in which we have a shared economic alignment in trying to provide care in an affordable way and a high quality way, because otherwise the product won't sell. And so these organizations, but more importantly, they're affiliated physicians. Each of the organizations I just described to you have very tightly affiliated physician organizations along with them. We're basically all owners of this particular product. The model basically calls for the physicians to be paid under capitation. Each of the institutions, when they provide services, are paid an identified rate for each institution. To the extent the organization is viable and there are funds left over, that can be distributed among the participants in a way to hopefully advance the purpose of the product itself. And if there are losses, we're all on the hook together to be accountable for those financial losses as well. So that's where, when I said earlier, economic alignment, but the payment model within that also calls for very important quality thresholds to be met before the distribution of any additional funds and things of that nature. So there are 2 levels of effort at both clinical efficiency and quality. One at the point of care, in terms of the way the payment model works, and then the collective performance of all of us together, right? All 7 institutions have an incentive to kind of look across all of us. And it basically is an effort, it's a recognition now I'll put my public health school hat on. It's a recognition that if we really do want to move to population health, then you need to have a model that rewards that. And essentially, keeping people healthier in this kind of model is one that can contribute to the economic viability of it long term. And when you talk about impacting a population in a densely populated area like Los Angeles and Orange County, you have to cover a big enough portion of the population to make a difference. And if I think everyone in this room has a general idea where all those facilities I just named are. If you think about that, that covers a pretty significant amount of the Los Angeles and Orange County geography. From a business standpoint, put the business school back on, from a business standpoint, that kind of scale is necessary to be relevant to the marketplace. You have to have that geographic scale in order to sell insurance, because this is Los Angeles. People live and work 60 miles from where they may live. They may work 60 miles away. They want to be able to get medical care, I think, from a common system or a common organization, wherever that might be. And so the geography of it, I think, will help meet that market test.
What do you think the top 1 or 2 success factors for this will be?
There really are several. The first is patient convenience and patient satisfaction. At the end of the day, if we're not geographically located in a way that's accessible for patients, and to the theme of your conference in terms of the future of healthcare, if we don't have the electronic infrastructure and the electronic access mechanisms, whether that's video visits or e-visits or mobile contacts, all of those kind of things, right? All of those kind of things, then we're not going to really satisfy the consumer of the future in healthcare. And so having those things in place, vitally important. That goes to the heart also of the quality that gets provided. And then the second part is we have to be good stewards of the resources, and we have to have the systems in place, and we have to have physicians who are committed to this model and who are committed to sharing information and sharing best practices and having the kind of doctor-to-doctor conversation about what is the right thing to do that physicians and their associated team members, whether those are pharmacists, nurse practitioners, the team model of healthcare, being willing to sit down, share best practices, compare notes, and figure out what to do for a given population.
But that's quite different, because people think that you're usually competing with these institutions and health systems, right? And now you're saying you're supposed to call someone up in Torrance and say, I think that this care makes more sense at your institution than mine.
Right. Well, first, the model actually, the essence of the model is if a patient signs up with a particular group. And the model is built on the expectation that virtually all of that care that can and should be rendered with that group would be done there. If people need a more advanced treatment in heart, cancer, neurosciences, the kind of things that we in UCLA might do, those patients may be treated in another setting. Mm-hmm. Good.
So I have a bit of a selfish question, because I don't know very much about this, and it still stays with the theme of new market relationships, new endeavors, population health. But I don't know if many of you are aware that there is a rehabilitation hospital going into Century City, which is conveniently located between UCLA and Cedars-Sinai. And strange bedfellows for the lay public is, wait, these two institutions are going in together on a hospital in Century City. So could you just comment about why you think that's good for the patient, the doctors, and ultimately the payers as well?
Sure. And there's no truth to the rumor that David and I had the hospital built there 30 years ago, so that when this day came, we could make that we could make that happen. But all kidding aside, well, a couple things. First, I think the characterizations, in general, the characterizations of competition, as well as the believed for benefits of competition in healthcare, I think are a little bit overstated. That's maybe a discussion for another day. But closer to home, I think also the competition between Cedars-Sinai and UCLA, I don't think is the kind of competition either that many people think of. In many respects, first of all, we're very different organizationally in terms of the nature of the organizations, and therefore have served historically pretty different kind of populations. Similar in many respects, but in other ways different. Specifically, but having said all that, I think what this joint venture represents a recognition that we're in a different era in healthcare, and that for organizations, especially like Cedars-Sinai and UCLA, one a state-owned institution that has a public obligation and a public benefit mission, and Cedars-Sinai as a not-for-profit organization, a public benefit. We do about $650 million worth of community benefit each year. We have a public benefit obligation as well, and that extends to asking the question, when it comes to meeting a community need, how can that be done in the best way that doesn't necessarily just serve our interest, but more importantly serves the public interest? And that's what I think is represented by it. So I know the two of us haven't noticed this, but the rest of the world's getting older.
Yeah, of course.
And the demand for rehabilitation services is growing very rapidly. And in that regard, the capacity of both Cedars-Sinai and UCLA is limited compared to what can be forecasted to be expected. And so therein lies the reason for undertaking it. But it also, on the business side, also, to weave in some of those thoughts, it also a recognition that when you're going to make an undertaking like this, that you also acknowledge your limits. And so while Cedars-Sinai we have a significant rehabilitation program, UCLA has one. There's a third partner in this venture called Select Medical, and this is a company that's based in Philadelphia that runs rehabilitation facilities around the country. So their scale and scope and depth of expertise in this area is much better than ours. And so the vision for this is to bring together their operating capacity with the academic, educational, and research and intellectual horsepower that Cedars-Sinai and UCLA can bring to it, to create what we are expecting to be the premier rehabilitation institute on the West Coast. That's the vision. About 125 beds, and it's probably open. Give me some wood to knock on. We'll probably be open sometime right after the first of the year.
Yeah, I think it sends a great message, too, that you're collaborators in care as well. Right. So we're running out of time. What I'd really like to, first of all, compliment the Healthcare Business Association at Anderson for being able to put this on, and it's just really very impressive. And so you have a fair amount of students in the room, and I don't know how many of you are aware of this, but it's extremely unusual and very impressive to have been at Cedars, at the helm, because you were COO even before that. That's pretty unusual in today's world, no matter the industry, to have somebody stay with an organization for so long. And could you comment for early careerists, mid-careerists in the room about why do you think you've had such a successful career? And any advice you may give them, or me, about succeeding and just how to turn themselves into the leader that you really are in this institution.
Well, that's very kind. Well, a couple of things. First, I want to thank you all for sticking around, too. It's beautiful outside, and the fact that you're here now is pretty remarkable.
Well, there are cocktails.
Right, yeah, that might have something to do with it. That might have something to do with it. So how have I been at Cedars-Sinai this long? Well, there's no truth to the rumor that I don't interview well.
What choice did you have then, right?
Right, exactly. No, all kidding aside, I've been very fortunate. In the class I teach, I tell people, my experience is 5 standard deviations out on the curve. To have spent 35 of 40 years basically in one place, and it's just the right sequence of events happened. What's allowed me, I guess, to keep the job is, I think at the end of the day, the most important thing is trust. People have to trust their leaders. And that's something you earn every day by how you conduct yourself, by the decisions you make, by the people you hire, by the people you fire, basically putting into action the words that people hear you say. Now, I'm human too, and I mean, I can't say to you that we pulled everything off perfectly. But when things haven't gone right, and some of you, this will be written about in the history books probably somewhere. We had a difficult time the first time we tried to create a CPOE system at Cedars-Sinai. That didn't turn out so well, and so part of trust and part of people viewing, I think, a leader with integrity is when things don't go right, you stand up and you say, we made a mistake. And that's essentially what I did in front of about 1,000 angry doctors one day. I don't suggest it if you want to sleep well at night. It's not the most pleasant thing, but and so essentially, I think I'd like to believe, by the way I've conducted myself over time, that when moments like that occur, hopefully you have a reservoir of goodwill, where the people who essentially are ostensibly supposed to be following you look at that and say, well, that's an exception. And then what you do after that is an important part as well. So we then use I'm just using that as an example because I think it makes the concepts more tangible. That we went through a pretty transparent process of asking the question, what did we do wrong? What did all of us do wrong collectively, and what did various of us do wrong individually? And we were pretty transparent about that. And again, those are the kind of things that build integrity. Just to try to end with a laugh here. A good friend of mine describes, when he's talking about leadership, he says there's a fine line between leading the parade and being run out of town by the mob. And so you have to strike the right balance.
Very good. So I want to make sure that we have a few minutes for questions. I'll put away my paper here and open up the microphones. And please speak right into the microphone so we can hear you.
Hi.
Hi.
I'm Laura Erskine from the Fielding School of Public Health. And as a fellow leadership instructor, I have a leadership question for you. Mm-hmm. You are, I think, both individually responsible for mentoring and developing the people on your team, but more broadly responsible for mentoring, developing leaders in the organization. And how are you doing that, given no one in the room really knows what healthcare or Cedars is going to look like in a few years, and how do you address, find, nurture both clinicians and administrators who will be poised to lead in a new era?
Great question. And I think your point about trying to develop people for the future, in a future that can't be described in great detail and specific, right? It does represent a challenge. On the other hand, I think there are certain important leadership characteristics that are generic and will be useful in the future. So integrity and trustworthiness, like I just mentioned, are two. Flexibility, another. The ability to deal with ambiguity, which is a character trait that I think in using measurement tools, and sometimes you just use your gut instinct, is there as well. And so our and then in our case, we try to work in a number of different ways of trying to bring our organizational values to life. And so our development programs for staff internally try to relate back to integrity and excellence, teamwork and collaboration, teaching people teamwork and collaboration skills, which especially for people who come out of medical school for sure, but also many other clinical disciplines, they haven't necessarily had any sort of formal training in teamwork and collaboration. And so those are some of the things that are part of the development effort. Another element is a specific effort to educate clinicians and especially physicians. And so for the better part of about almost 20 years now, we've had a physician leadership development program, specifically because we do believe to deal with what we have to deal with in the future, having physicians in those roles is vitally important. And so a specific education program to try to identify those future leaders and hopefully give them the skills. In a curriculum, frankly, it's borrowed, some of it's been borrowed and done cooperatively with the Anderson School in the past. And many of our physicians and other folks have been come through the Fielding School as well. So we try to do what we can internally, but also make use of placements in formal education programs.
Good. Any other questions?
I had a question about the Vivity business model, and I think I read that it was compared to Kaiser in that it was kind of posing a competitive model. And
Right.
at conception, was it ever framed that way? And could you speak more about it?
Sure. Yeah, a lot of the press around it did characterize it as basically an effort to try to compete with Kaiser. And personally, I think that's a misrepresentation. It is similar in the sense that it uses a capitated payment model. It is similar in that it's a different way because, for those of you familiar with Kaiser, Kaiser's really 3 separate corporate entities bound together in using a particular set of agreements, long-term agreements. So Kaiser is not one unified corporate structure, actually. This is not one unified corporate structure either. It's 8 different organizations that are coming together using an LLC model. So it's similar in that it's knitting together disparate organizations. It's similar in that it's using the capitated payment model, and it's built on it is an insured HMO product. That's what the Vivity product is today, is an insured HMO product. But to suggest that it was done to compete with Kaiser, I just don't think that's an accurate representation. It was done most of all because, as I said in the beginning, the participating organizations believe that way of organizing and paying and providing care is a very good and appropriate way to try to deal with these issues that we're trying to deal with in healthcare, to do it more cost effectively and do it in a high quality way. Invariably, we're going to bump up against Kaiser. They're 30 or 40% of the commercial market. So are we going to bump up against each other, and is there going to be competition? Yes. But that's a far cry from saying we're going to compete with them. They're 50 years, they've been at this for 50 years. So, if I were in their shoes, I'm not sure I would consider us, but I'm just kidding. They should be very scared.
You did not hear this in this room.
No, I'm sorry.
Because
I don't mean
it's an HMO product. Of course, they compared it to Kaiser. It's the best-known HMO, right?
I shouldn't be making light of it. I've had my own frustration with the degree to which it's been characterized as an attack on Kaiser, as opposed to recognizing that we believe this is a great way to organize and pay for health care, and these are great institutions that have come together to make it happen. To me, that's the most important thing.
Hi.
Hi.
So I have a question speaking to, as I mentioned, as Dr. Vriesman mentioned, a lot of the students in the room. Mm-hmm. Coming from someone who went through a public health program, and for all of us going through MBA programs as well, what do you wish you had known earlier on in your career that you would like to impart your wisdom upon to all of us going into the healthcare field, hopefully in the future, and becoming as successful as you one day?
Great question.
Wow. Well, I think probably the same, in some respects, the same as anyone once you get to, my particular stage in life. In retrospect, I wish I hadn't sweat some of the details that I did. But at the same time, to be honest, I think that kind of, I also think that kind of mentality is part of being successful too, right? You do have to worry about the small things, and they do make a difference. To me, the most important thing is to have a passion for what you do. What I've ended up doing in my life was not what I thought when I graduated for the historians in the room, I was in school in the mid-70s in health planning. When health planning was going to be the way that we were going to solve the healthcare problems in the United States once and for all. And so I was going to be a community health planner. Along the way, I ended up doing an internship in a teaching hospital in Pittsburgh, and when I saw it, I said, that's what I want to do. But so there's a serendipity. Be ready for serendipity in your life. Take advantage of it. But most importantly of all, have a passion for what you do. Because everyone in this room, by virtue of the fact you're sitting here today, means you are very achievement-oriented people. And so it's hard work. And so you have to have a passion for what you want to achieve. That's the most important thing of all.
with that, I can't imagine ending on a higher note. So thank you.
Thank you. Happy to do it.